Hi, my name is Jens Lundgren. I'm a professor of infectious disease and a practicing infectious disease specialist at the University of Copenhagen in Denmark. It is my sincere pleasure to welcome you to this discussion on shaping antiviral therapy around individual needs, how to maximize adherence and quality of life. I'm here with Professor Marta Boffito. She's a consultant physician at Chelsea and Westminster Hospital and Imperial College London, as well as a clinical director of HIV, sexual and gender health dermatology at Chelsea and Westminster Hospital in London. I'm also very privileged to be joined today by Angelina, Namiba, who has over 24 years of experience of working in the HIV sector as an advocate for people living with HIV. Today's program is divided into three themes. The first theme focuses on how to ensure that the individual needs are taken care of as we are approaching patients who are starting on treatment. The second theme is which considerations to make around which of the available recommended antiviral treatment regimes that is the most optimal for that individual patient. And then finally, looking at the long-term perspective, how do we monitor the individual needs as treatment is maintained over many years and age and other issues becomes an important part in people's life. So let's start here with the first topic, how to address individual needs and personalize the assessment as people are starting on antiviral treatment. Clearly, as healthcare providers, our job is to be able to assess patients' readiness to start and maintain antiviral treatment at that point before we actually start the regime. I think there is global consensus, I certainly hope so, that starting antiviral treatment is recommended for all newly diagnosed patients living with HIV, regardless of their CD4 cell count. This has been in place since 2015. And therefore, anybody that is started on treatment, also those who don't have symptoms from HIV, should really be carefully assessed for whether they are actually ready to initiate treatment. The ARS guidelines have put out an approach, a systematic approach to how you can assess and understand people's readiness. And please address those the questions or those stages as you are evaluating and talking to individual patients. We know from surveys that there's barriers in the communication between the healthcare provider and people living with HIV. Quite surprisingly, 1/3 of people living with HIV with treatment-related concerns feels uncomfortable discussing these concerns with a healthcare provider. The main issues for why that is not the place for those who are concerned is that for some it's essentially a despair that nothing much could be done with those concerns. Another reason for this is that the healthcare provider never brought up the issue or asked them in an open way. And for some, it is the fear of being labeled as a difficult patient. So with those introduction comments, let's get to the panel. We have some questions that has been identified by a wider target audience consultation that we'll now have a discussion with our two panelists around. So your reflections, maybe Marta, as a HIV physician, you have been in this situation many times, talking to people who's in this situation of starting a therapy. What's your thoughts and what do you focus on in your conversations and assessment of people's readiness?
It's a great question. And of course, it's very important. It's very important to have conversation and to ask questions and really try to feel where the person in front of you is in terms of being prepared to start and understanding how important it is. I firmly believe that it's a journey that the person living with HIV and the doctor have to take together. And the doctor needs to make sure that, again, a lot of questions are asked about the situation, how the person lives, how they feel, comorbidities, other factors that affect their life. And I think that today we are and we should be confident in telling people that the medications that are available, although are still a bit of a burden because, of course, people need to take pills or medications in general for the rest of their lives to control viral replication, are easier to take and better tolerated than they used to be in the past. So there could be some reputation of antiretroviral therapy that history brings with itself that increases the fear of people. So I think reassurance is very important. And then just to introduce the topic that I think we might develop is also something I strongly believe in is implementing services like peer support in the services that provide care for people living with HIV, so that if the fears of the person that has to start are not addressed by clinical care providers, there's other tools to support people in starting treatment.
Excellent answer. Thank you very much. And it really is a good layup as well to you, Angelina, as a patient advocate and with vast experience. I'm sure you have been involved in peer discussions with patients who are in a difficult situation. Your perspective?
So in terms, thank you very much, all the things that Martha said, but in terms of my perspective, I think you're right, it's really important to look at what some of the barriers are. And this could be many, including, just denial of the HIV status itself, lack of actually understanding how treatment works and what the benefits are for a patient. There could be also other issues with just practical issues with adherence. I think it's really important to explain just in very simple language about how treatment works and why you need to take it every day. Because a point that Martha raised was around the historical issues around maybe what medication was like before, because patients might then say, well, why do I need to start treatment straight away? So it's also really important to understand and explain the benefits of starting straight away, staying well for longer, etc. But I think in terms of some of the other issues and explaining how and why it's important to start and just looking at what patients might not be ready, it's about also familial circumstances. Who do they live with? Are some of them experiencing intimate partner violence that affects the ability to start treatment? So looking at, some people have religious beliefs around treatments. But it's also just very much explaining and making reference to actually, sometimes you can use examples like, well, when you have a headache, you do take a pill for that to go away. So think about it as, this is something that's going to help you to be well. But it's also just making sure that people can relate to, the benefits of taking treatment. But also, I think I just wanted to mention the other thing was some of the tools that we might use in terms of making patients understand that taking treatment is only a tiny part of their lives. They have lots of other things going on, so they can just fit treatment in with this stuff that they do every day.
If I may add something, sorry, Jens, it's very helpful to hear Angelina's perspective. On top of all of that, obviously, mental health is really important, assessing anxiety and depression, because the literature is quite clear nowadays. Recent data show that the quality of life of people living with HIV could be good, could be the same of the quality of life of people without HIV. However, anxiety and depressions are more frequently diagnosed among people living with HIV. So if we make sure we address that, when that is addressed and support, adherence to treatment, engaging in care are higher. So I think that's just to kind of complete the picture. And I think this is a very important piece of information to share with the person you have in front of you that needs to start.
Excellent, thank you. One thing that I have come to see quite a lot of times is that people are concerned that once they start on treatment, they need to obviously carry the medicine with them, and that essentially is disclosing their HIV positive state, which they may want to disguise. I mean, it's a very practical issue when they cross borders, etc., etc. How do you try to overcome that concern, which is legitimate to obviously, because people should not disclose their HIV status except for if they want to do that, and this could be the way that would unintentionally lead to that. Angelina, have you heard about that as a barrier? Is that a concern?
Yeah, it is a concern for some patients, but one of the things you can say is about, for example, for somebody who's aging like myself, I do have comorbidities. So I have lots of other pills that I'm taking. So in terms of traveling, you can just put them all together in a little pill box so that you can't differentiate whether this is the HIV medication or this is my high blood pressure medication. So taking it along and not making it a big deal in terms of, so that's if you're traveling abroad, for instance. But in terms of day-to-day activities, most people are now taking medication maybe once or twice a day, for instance. So what we advise is fit the medication in with something that you do every day. So for instance, you wake up every day, you brush your teeth, you have a shower, you have breakfast, a cup of tea. So maybe fit that in your regime. So you take your medication in the morning after you brushed your teeth, or in the evening before you go to bed. That in itself for the whole day means you don't have to carry the medication around. But in terms of traveling, you just put it with everything else that you take, whether it's vitamins or whether it's, other medication. So that it's not like specific pills for HIV, it's just all together. And then don't make a big deal of it because it's only a small part of your life.
Absolutely. Very good. Thank you very much. Excellent discussion. Good points that both of you are raising. All right, let's move on to the next topic. How we want to make sure that there's shared decision-making in the selection of which ART regimes that patients are started on. Also here, there's obviously a good footing to have that discussion on, namely the guidelines here reflected by the ARX guidelines from last year, recommending that patients are initiated on a regime of 3 drugs. We won't go into the details of the specific drugs here, but just to say that these guidelines are obviously based on the best possible evidence that is available, and that is of course important as a premise for this discussion. We also know that there are specific and important considerations that you need to take into account in your final selection. For women, are they contemplating potentially being pregnant? Do people have a intervening infection? Tuberculosis could be a problem. Do they have comorbidities? Do they take other medicine? Are there drug-drug interactions issues? Problems in swallowing? Was the HIV required while people were on PrEP? So there's a lot of factors that we obviously as physicians need to consider when we are making our choices. Importantly, surveys have indicated that many people, HIV positive people, are really interested in being engaged and understand what that selection is, rather than you as a physician say, I think this is the tablet for you, but you explain why you think this is the best option and give alternative if those are reasonable. So on that note, there's a couple of questions that I would like to discuss with the panel from audience that have been contributing with those. So to you, Angelina and Marta, what do you consider, maybe starting with Marta as a physician here, involved with those decisions probably very regularly, What are the key factors that you consider, given the current state of the drugs that is now recommended? What would be your focus when you have a patient in front of you that which is ready to start on antiviral treatment?
Yeah, so having obviously reviewed, the medical aspects, the biological aspects, such as the presence of resistance or not, or very high viral loads, or very low CD4, or certain comorbidities, obviously, inevitably, you have to do your doctor's job first to ensure that the general recommendation on the guidelines can be implemented. So just beyond that, I think it is really important, again, to understand what is the lifestyle of the person in front of you at the moment. Do they work? Don't they work? Do they take other medication? Don't they take other medication? Can they swallow pills? Can they take pills every day? Do they work shifts? Do they have, again, comorbidities, other because they're aging or because their mental health at the moment needs support with medical treatment? So I think this kind of discussion with people living with HIV regarding selections are important. Within the context of comorbidities, we can look about metabolic comorbidities. It is a very good opportunity, I think, to talk about diet and healthy lifestyle. I think it's a conversation we should have anyway. So that could be, part of the conversation when you select antiretroviral treatments. And then just to say, I'm a big fan of 2-drug regimens that can be used because why using more drugs than you need when you can use only 2? So that's also, I think, something that can be taken into considerations if there is no hepatitis B co-infection, for example. And that is very clear from the EX guidelines that you showed.
Yeah. Angelina, my experience is when you start to explain to patients who is in the middle of a very difficult decision-making process to begin with, and start to overlay them with all the different medical aspects that comes into what you would be recommending that patient to start on, and try to involve them in that discussion. Some people feel that it's just too overwhelming. So, doctor, please tell me what you think I should take. Is that the wrong way? And how do we deal with that? Because on the other hand, we obviously can agree on that it's important to involve patients in your decision-making process. Isn't that a dilemma?
You're right, Jens, it is a dilemma. However, like everything else, we have different types of patients. So for instance, you have those patients who are very, very treatment literate, who want to be informed in every particular decision that is made about their treatment. Then those ones, of course, when you start to explain to them, they're quite happy to go into deeper discussions. Then you have the patients that you mentioned who are very happy about, the patient, just the doctor making the decision about what medication to take. And it's not because they're being patronizing or anything. Sometimes for some patients, it's too much to take in. So you know what, you're the expert, tell me what I need to take. And then you have the other group of patients who may not have so much information about treatment or have treatment literacy, or may come from cultures whereby you don't really ask a doctor anything. So for instance, where I grew up, we take doctors, they're in almost like gods in a way. So if a doctor says something, you don't question them. So that group of patients may well want to have more information about their treatment regimen, but may not feel confident or comfortable enough to ask. So sometimes it's just best to take a minute, as a clinician, to gauge which type of patients you're working with. And if the patients want information, you give it to them. One who doesn't need information, you give them that, you try and help them to make the decision. And those ones you think may want more information, but I'm not clear about it. That's where, and Marta mentioned about the importance of peer support, because there are, peer supporters who have lots of treatment literacy information and have the time to sit down with the patient, explain things in a very simple way. So for instance, I did do treatment literacy workshops with patients, but it's about having that time to explain things in a very visual, because some of us, I like to see things visually. I like to see things, maybe you draw them down for me, and I have the time to do that. So it's just about gauging what type of patient it is and what kind of information they need or not.
Excellent point. I do recall a lot of situations where people have read a lot of things coming into that discussion, is really engaged, and then the other patient that essentially is overwhelmed and just tell me, doctor, what I should take. But it is important, Marta, isn't it, that for this latter patient to really also get them to speak about this, either at one consultation or come back to that at subsequent consultations. So how do we create that space in our conversations with the patients so they feel, although they are overwhelmed, that we actually get to talk about these issues, which are important because people need to be involved and understand why we have made the choices that we have made?
No, absolutely. And this is our challenge of creating trust in people. So I think around the description of adverse events, for example, I personally believe that it's better to talk about the adverse events. Everybody knows that drugs have adverse events. There is no point of saying, oh, you'll be fine. Drugs have adverse events. Talk about them. Tell people in front of you what's the percentage or what's the risk of developing adverse events, what are the rates of discontinuation because of adverse events. I think this is a very important piece of information. And also what I always say to people when they start treatment or they switch treatment, we are here for you. You're not stuck with this medication that gives you side effects. I don't want you to be home miserable, having side effects. You please need to come back and tell me, because I have done this job for a very long time and there are other alternatives. Don't fear of telling me that this drug causes this. If that's what you think, you're probably the best person, the most entitled person to say that. And then we're going to have a conversation. And I think this needs to be very clear, even for those patients that you were discussing, that are those that express less the need to express what they want, because you need them to trust you and to be able to come back and say, sorry, this is not for me.
Big topic about trust. Angelina, just here in the end, how do we ensure, at least try to ensure, that trust is being developed? Because I think we can all agree that it's important that the patient feel that the healthcare provider that is in front of them actually have the absolute best needs in mind.
Okay, so I think it's very much about, there's a couple of things that you can do. It's about actually really listening to the patient and hearing them and trusting them and asking them open-ended questions. Because sometimes as a patient, I'll come to the consultation, and yes, you'll ask me, Angelina, so how are you today? And my first instinct is to say, I'm fine. But if you push a little bit more and ask, are you really fine? I'll tell you a lot more. So I think in terms of, from the clinician's perspective, I kind of came up with this little mnemonic which says listen, which is about really listen, to hear, to insist on a response, and summarizing what you've said. Because sometimes you may say to me, this is what's going to be happening, and you think that I've had, but actually I haven't had. And then just trusting what I say. And what we also do encourage patients on the other side is to, like Marta mentioned about the side effects, and to be prepared when I'm coming to see you as a clinician, even just writing down, so how, what is the side effect? How often does it happen? How severe it is? How much does it affect my quality of life? Because then in that way, Marta can then make a decision based on that information and actually deal with me better. So it's just about both of us being, me as a patient being very honest with you, and you as a clinician really listening to what I'm saying and taking it on board.
I think that's probably the best advice HIV clinicians can get. Listen to your patients and give them the space to actually explain how they truly feel. Thank you very much. So let's go on to the third topic. The focusing on the need to monitoring individual needs and rationalization for ART adjustment, as this treatment obviously is for the life of the patient. We know that there are barriers to antiviral treatment adherence. We have talked about them in other segments: lack of social support, fear of disclosure of HIV, potentially economical constraints, forgetfulness, religion, concerns about adverse reactions, also maybe from other prior drugs that is no longer used, that still is talked about in the community, comorbidity. And some people obviously is concerned about pill burden, in particular if they're not able to get a 1 pill a day regime for various reasons. On the other hand, we know that there's a lot of facilitators, which is of course then the opposite. Positive social support, getting family responsibilities, reminders, just continue to emphasize the beneficial impact of antiviral treatment, and in some situations that you as a healthcare provider have telephone conversations. So there is a lot of factors that can rationally be considered if you want to adjust an ART regime. You may want to simplify it, you may want to switch to a more adherence-protected regimes. The newly introduced long-acting antivirals, injectables, is a potential possibility. You clearly want to make sure that if people is not tolerating whatever drugs that they are on, that you want to switch them to something else. Patients may start other drugs that poses a drug interaction issue that you need to deal with. Protection against HPV infection, in particular if you're choosing a 2-drug regime, is something you really need to consider. Planned pregnancy. You may want to fortify your regime, so to make sure that if there is a problem with adherence, that resistance risk is reduced, and in some situation there's also adjustments required in order to reduce costs. So again, coming to our panel with some of the questions that we have received from the audience. Marta and Angelina, how do you, and maybe Marta, if I can start with you here, how do you emphasize the importance of continuous long-term adherence? How do you do that? Because this is a conversation we should have to begin with, but obviously we'll see patients for many years. How do you continue to say this without sounding like a broken record?
No, good question. I probably do sound like a broken record. However, I think one of the most important thing is that the person that you see in clinic is happy, that's probably a bit extreme, with their combination and with the fact that they're taking pill, or is comfortable with that. Because then you have some room for discussion on how important it is to remember the tablet every day, because that is associated inevitably with well-being from a general health point of view. One of the aspects around this is to make sure you ask people every time you see them if they're still happy with what they take. As you are probably aware, we have a document called the ViiV Standards that have been written by people living with HIV that are really helpful in guiding us on what assessment to do, but also what questions to ask at clinical visits. And one of them is, are you still happy with your treatment? Are you still aware how important it is to take your treatment every day? Are you still able to take your treatment every day? So I think this is something that can help, because obviously with new combination, new medications, new choice for people living with HIV, I think it's important that all of this is reviewed regularly, rather than just looking at viral load. And if it's undetectable, just, get on.
So are you happy with your medication? I think it's a good lead-in. Angelina, I'm sure you have had those discussions many times with people in your network as an HIV advocate. What is the discussion? How do the patient community think about their consultations with physicians? Obviously, the ViiV guidelines have been updated, and there was involvement of patients in formulating the guidance that Marta was just referring to. What do you hear?
Gosh, it depends. It depends on who I'm talking to. The patients who know about the ViiV guidelines and who are well informed. So, for instance, we have a member network called the UK Community Advisory Board, which is made up of people living with HIV, some of them treatment advocates. So they, they tend to provide patients with a lot of information about what's happening, about treatment, about what kind of care you should expect to receive. So a lot of patients who are on, membership of organizations like that tend to get the information that they need. In terms of others who are not linked in to organizations like that or membership like that, may not have so much information about it. So I think it just depends. It depends on who you're talking to. It depends on where they access the care. It depends on how confident they are in terms of asking for what they need. So it varies. It varies. But what we tend to do then, if you hear that somebody doesn't get the care that they need, then it's incumbent upon us who have the information to make sure we pass it on to them. It's the least we can do.
So Marta, I mean, the continuum of care overview informs us that in many countries, it is actually possible to maintain adherence to the level where HIV remains undetectable in the overwhelming number of patients. That was not the case 10, 15 years ago. So what are we doing better now that we were still lacking behind 10, 15 years ago?
Yeah, good point. So new drugs are better tolerated, easier to take. That's definitely an aspect. There is more choice. I mean, today we even have long-acting treatments, so people who can't take pills can actually opt for a long-acting treatment that doesn't need pill taking, and that has brought remarkable advantages to the quality of life for certain individuals living with HIV. We know much more about resistance and how to overcome resistance, how to prevent resistance. We know much more about how to support adherence. I always talk about peer support as a very important element, because for us, peer support is really helping to fill in the gap of people who struggle with taking pills. Peer supporters are knowledgeable about living with HIV and are able really to share their experience with other people and promote their engagement into care, for example. Also, we know much more about aging, comorbidities, certain areas of life that is indeed inevitably life also for people living with HIV, because they do belong to their general population. And we know, and their physicians, and we know about, which treatments are better in older people, or how to support older people, maybe because they have impairment of their memory or difficulties with swallowing. And so it's all about knowledge and experience, I think.
Angelina, here in the end, if I can just ask you, the situation for many HIV positive people is that they were on HIV pills as the only type of pill for many years, but are now, due to their age, as alluded to also by Marta, comes into an age range where they start to have other comorbidities, and the number of pills that they need to take every day is mounting. How are people dealing with that? Is this a concern in the patient community?
Yeah, indeed, it is a concern. I mean, I'm one of those patients, even though, of course, I only look 35. But actually, I am one of those patients, and I take quite a lot. So I have for my blood pressure, I have for my bones, also all sorts of medication. So I think it can become quite a burden. However, saying that, I just wanted to just push back a bit in terms of, if we're looking at long-term taking medication, there are two groups of us who are, you could say treatment fatigued. So there's people like me who've been taking treatment for a long time, 20, 30 years. And then there's young people who are born with HIV who've also been taking medication for all their lives. So in a way, we can kind of be in the same group in terms of, we don't get tired of taking medication, but we have to take it. And it's about how do you then fit it into your life. So for instance, I would take most of my medications in the morning, but then there's for example, medication that I need to take for my cholesterol, which is better taken at night, for instance. So it's about how you fit it in. It's a lot. So I think, and I know you haven't asked me this, but I think there's so many of us could actually benefit from taking something that is long-term acting. So, so some of us who are treatment fatigued, that would be one less pill to take, or a couple of more pills less to take. There are people who are maybe long-term inpatients who may, and I'm thinking about my own example, when I was an inpatient for 6 months and I was on an NG tube. And, I used to watch the nurses crush my meds to liquidize to be able to put it in the NG tube. So somebody in the hospital for that long, I could have just taken maybe, injecting medication for maybe 3 or 4 times. There are patients who are sometimes experiencing intimate partner violence within their homes. And for them, if that is the only pill that they're taking, maybe it might be, it's a way of, it's convenient, it's safe, it's confidential. So I just think, in terms of the old ass of taking a lot of medication, if there's a way we can find to actually make us take less pills, we know we need them, and of course we want to take them. It just works best. Thank you.
No, certainly a new treatment possibility that we didn't have 5 years ago, which is great, but also to some extent also quite cumbersome, although it alleviates some of the issues, Angelina, that you're pointing out. So thank you very much, both of you, for an excellent discussion on this topic here, a very important topic. My role is just to thank you all for listening in on this dialogue. I want to thank Marta and Angelina clearly for their important insight from different perspectives on the 3 topics that we have been discussing.